Hello, everybody. Hello, everyone. I'm back. I'm here to continue with the heart, a big chapter, one of my favorite chapters as well. Trying to get into the discussion that integrates the blood. We're going to kind of integrate blood, heart, and vessels, right? So it's a neat sort of trinity of systems here. Get this going. Okay, so at this point, you should now be experts at blood, all the ins and outs of blood, all the details, the components, formed elements, plasma, all that stuff. So that's the first of our, as we mentioned, our trilogy. So the first part, a very important part of the cardiovascular system. Now, you're going to learn a lot of stuff this semester, but the cardiovascular system, you are going to learn it in detail, right? So all of my students, I can say, come out of this course experts at cardiovascular system. So, and when I say experts, there's still always much more to learn, but you're going to be very, very proficient with this system for a couple of reasons. In the United States right now, most people that have medical issues, it's going to be some sort of cardiovascular disease, some sort of heart issue, some sort of clogged vessel, that kind of stuff. So very, very important system, very relevant, very applicable system, and something that for you nursing types is going to be right up your alley. For you physical therapy, for you athletic types, again, also right up your alley. You cannot perform at high levels of intensity if your cardiovascular system is not up to its optimal level. So again, a lot of aspects that we're going to attack this this trilogy, at or by here. So let's look at now that second one, which is the heart. And I get some emails sometimes, sir, how do you approach the lecture, right? And I hope that you've started to see, I'm not just reading page by page, word by word from the Ammerman book. I think I'm trying to pick and choose, especially in the summer, it goes so fast, trying to pick and choose the key points of each chapter. So no, I'm not following along. To me, that was a very, very boring way of reading, of learning, going to class, having the instructor read out of the book and just highlighting the book. So you may have to bounce around a little bit within the chapter, but based on my experience, this is the way that seems to work best, right? I hope you do find some logic to the way that this thing is being presented. Right? So we're going to start talking about the heart, but before we talk about the actual organ, we have to go back and look at the individual cells, right? So it's the cells that make the organ possible, right? So cells make tissue, tissue then makes organs. So cardiac muscle. This is from 2401, right? Old stuff that you covered last semester. Cardiac muscle is unique. It's one of the three types of tissue, right? These cardiac cells, cardiac tissue is different than skeletal, different than smooth type of muscle. So when we start to look at basically the muscle, right? Myo refers to muscle. And then cardium is going to refer to the sort of heart area. So the cardiac muscle is the type of muscle that comprises the heart's myocardium. So there's a misconception that the entire heart is made of muscle. That's not true. There's some connective tissue within the heart. There's the contractile muscle, the myocardium of the heart. There's valves. There's hollow areas. So we're specifically looking at the myocardium of the heart, the contractile tissue of the heart. So the cardiac muscle itself is not reliant on nerve stimulation for contraction. So the heart can, in essence, generate its own beat. It can contract on its own. It can initiate its own depolarization, and that should mean something to you from last semester. It is autorhythmic. It generates its own beat, but it may be influenced by the nervous system, and it's commonly influenced by the nervous system. So if you get scared, if you're excited, all that will trigger a faster heart rate. if you learn how to calm yourself, maybe yoga, meditation, whatever, you might be able to kind of slow and relax that heart rate. So, but the heart itself is triggering its own depolarization. That's going to be a whole lecture on its own there, but important sort of vocabularies there. So I did upload a little video. I'm a big fan of the Khan Academy videos. I'm a little bit jealous. That guy knows how to use that tablet really good, really effectively. I'm nowhere close to that proficiency. I spent a lot of time this morning and still haven't improved much on that. But the cardiac muscle, I encourage you to watch that video. It's kind of slow, maybe kind of drags a little bit, but it's important to put you in the correct mindset to understand the individual cell. You're trying to understand this whole organ. Well, you can't understand the whole organ if you don't even understand that little individual cell, that cardiac cell. So please, please, please watch the video and link it into this discussion here. The cardiac muscle, the microscopic anatomy of it, right? So these cardiac cells are striated. That's not new. You've heard of striated muscles. It's involuntarily though, right? It's not like skeletal muscle that's striated and voluntary. Cardiac muscle is involuntary. It's shorter. It's a fatter cell, and it branches, right? So it's not linear like cardiac, or I'm sorry, it's not linear like skeletal. Cardiac is going to be branched cells. We have these intercalated discs. Those are very important. They're like a glue, if you will, like a connection that holds two of these cells together. Remember, these cells are going to be having to pull and contract and generate force. So we need an attachment point, a point of leverage, and that's these intercalated discs. Gap junctions, right? Gap junctions are basically little holes, little openings from 1306, right? Biology 1. These are little cellular junctions that allow communication from the inside of one cell to the inside of the other cell. They're like little tunnels. If you can envision a hamster cage where you have two little tanks, and then there's a little tunnel that allows that movement, right? Or if you're a fan of El Chapo, right? He has this area and this area, but then he's got that tunnel that links the two. That is the gap junction, right? It allows the chemicals, the ions, the sodiums, the potassiums. It allows the cytoplasm. It allows this electrical coupling. It electrically couples the cells, and it forms what we call a functional syncytium. It's a fun word to say, functional syncytium. This is a fancy way of saying a team, right? And if you remember the Three Musketeers, right? All for one and one for all. It's basically allowing this whole group of cells to act as one entity. Right? When one cell decides to contract, it sends that signal to the others and they all contract. Right? When one decides to relax, they all relax. And that's only possible by that gap junction. Right? So important. Comparing and contrasting now T-tubules. T-tubules are wider but less numerous than the regular skeletal muscle. The SR, sarcoplasmic reticulum, is simpler than in skeletal muscles. So again, there's some similarities, but there's some critical differences that if you learn them, if you remember them, I think it's going to make a big improvement on how you understand the individual cell and how calcium is moved around, how that depolarization happens, right? So important aspects here. And again, we have an organ, the heart, that basically works and works and works and continues to work, right? Maybe you had a long day. You're happy to go home, sit down and relax, right? Give your legs a little break, right? Well, think about the heart. The heart doesn't get that break, right? The heart is beating the whole minute, the whole hour, the whole day, the whole week, the whole year, the whole life, right? Even before you were born, your heart was already beating. So the heart does not have the luxury of taking a break, right? It must work. And if you're working out, if you're being active, if you're really under stress, you're not eating well, putting more work to the heart, that heart is having to work even more. So it is adaptable, and it does have a tremendous amount of mitochondria. That mitochondria allows that heart to have the ATP required for that lifetime of work, of beating. Yeah. So important aspects. And I'm going to say that a lot, important. If you have a blood issue, well, we can get a transfusion, right? If you have a heart issue, well, yeah, we can get a transplant, a heart, transplant, but really it's going to have a tremendous impact on your life, on your health. So this is a very important pump, and we got to really appreciate all the work that it does for us throughout our life. So again, a lot of words. Now we have some pictures here, right? So there's our striations. We have our, again, our SR, sarcoplasmic reticulum, our transverse tubules, the T tubules, right? We have then our nuclei, our intercalated discs. So basically, the video does a really good job of illustrating this better than a static image. But again, really try to get an idea of the individual cell and how it looks, how it works, how it helps the entire formation of that heart. So the gap junctions, again, allowing for electrical coupling. Inside of cell A can communicate with inside of cell B, right? Very easily. All those intercalated discs where we would have the gap junctions. Intercalated disc, we would have gap junctions. Intercalated disc, we'd have gap junctions there. So again, the anatomy of the cardiac cell. So cardiac muscle has a unique physiology, right? Cardiac muscle, it's like these kind of people that maybe you're that type of person that you're not a picky eater. Whatever they bring to you, yeah, I'll eat it, I'm fine. There's some people that are very picky. No, it's a little bit undercooked. No, it's a little bit overcooked, right? The heart is not like that. Any molecule that is able to be metabolized for energy, these cardiac cells will utilize them for energy, right? It will use any fuel source, even lactic acid, right? Lactic acid is that burning sensation. Well, that's fine. The cardiac cells will take up lactic acid and they'll metabolize it for energy. So the heart will probably never starve, right? There's so many fuel sources, so many cells, so many molecules that cardiac cell can metabolize. Right? It will never starve for energy, but there's always a risk that it can be deprived of oxygen. So that cardiac muscle, the cardiac cell can do so much, work so hard as long as it has oxygen. It cannot incur an oxygen debt. To incur an oxygen debt, let's say I'm going to dive to the bottom of the swimming pool. I hold my breath. I swim. I come up, and then I'm going to be breathing a little bit hard for a little while to kind of catch up that deficiency of oxygen. I'm going to sprint. I'm going to try to run the race, sprint really fast. After the race, I'm going to be breathing really fast until I pay off that oxygen debt. Well, skeletal muscles can do that. The striated muscles can do that. I should say the smooth muscles can do that. Cardiac muscles cannot. They cannot incur an oxygen debt. So that's their Achilles heel. That's their vulnerability. They cannot go long periods of time without oxygen. Now, I have studied anatomy. I have studied hearts, comparative anatomy of many different vertebrates, of invertebrates, and I've yet to find a heart that actually looks like that. But that's the image that most people associate with the heart, right? It's this sort of heart-shaped picture, right? So I don't know. If you find out what species that belongs to, please let me know, right? The heart. That's more realistic, but that doesn't sell very well on Valentine's cards, I don't think, or little emojis to say you love something, right? But this picture is the anatomically correct sort of external view of the heart, whereas I don't know what that is, yeah. But here we have the heart, and if we were in lab, and you are going to have some assignments that allow you to kind of get some lab practicality, lab experience. We start to look at certain landmarks. We have that big groove. We have a little point, a little apex there. We have, some important landmarks on the surface of the heart. So I've always been more fascinated by the physiology, right? The anatomy to me is very dry. We can memorize it, but that doesn't mean we really understand how it works, right? So I can memorize all your names. That doesn't mean I know your motivation. That doesn't mean that I know your, what you like, what you don't like. So don't get that misconception that just because you memorize the anatomy, you know how this stuff works. They're two very, very different things, right? So we get into some anatomy, and I'm going to then dive into the physiology here. So the heart is approximately the size of your fist. Right? So imagine that fist located in the mediastinum between the second rib and fifth intercostal space for that 2401 boring anatomy stuff, right? It's on the superior surface of the diaphragm, so above the diaphragm, 2/3 to the left of the mid-sternal line. So it's not directly on that middle line, right? It's 2/3 to the left, anatomical position, right? So the left side, 2/3 to the left. Anterior to the vertebral column, posterior to the sacrum. So behind the sternum, in front of the vertebral column. So everybody kind of knows where the heart is, but that's the anatomical description of that location. Now, in red, right? Red word here, right? The heart is enclosed in the pericardium, right? If I'm looking at the perimeter of an area, right? Peri implies sort of that outer, the perimeter of a circle, perimeter of an area. So around the heart, enclosed in the pericardium, it's a little pouch, a double-walled sac that surrounds the heart. Right? And that's a key modification, and there's some reason for this pericardium there. So again, all the words. Say one picture is worth 1,000 words. Yeah. So there's the heart. There's the major landmarks. That apex, the point of maximal intensity, right? So if you've ever gone to the doctor and they get their stethoscope, sometimes you get worried like, man, they can't find my heartbeat, right? They're doing that kind of mess. Well, what they're trying to do, they're trying to position it to listen for different aspects in different areas, right? So again, that's that point for moving that stethoscope around. Okay, so we have now the anatomical view. You're looking at the patient as they're lying on the table. Our pericardium has been cut. So the pericardium, that bag that surrounds the heart, has been cut. So now we see the heart itself, right? The apex pointing to the left. The heart kind of in between the two lungs, protruding into the left lung a bit, right? It's not right in the midline. It protrudes more to the left side. There's our diaphragm, the major vessels that we'll talk about a little bit later. And the pouch, right, that sac, I want to talk about it here, the pericardium, right? The pericardium is a deep two-layered serous pericardium. Parietal layer lines the internal surface of the fibrous pericardium, visceral layer, pericardium, the external surface. So words. Okay, what does this all mean? So in essence, we have this bag, right? This pouch that two key aspects here, right? As that heart is beating, that would generate a lot of friction, right? let's say we go out and we work in the yard, man, we're going to get some friction. We might get some blisters. You have friction on a new shoe or something. It rubs. You can see how that would then cause blisters, cause calluses. Well, we don't want to callus up. We don't want to blister up the lungs, right? Those are vital air gas exchange organs. So in order to minimize friction, we have this bag lubricated with this pericardial fluid, right? It's a viscous fluid that minimizes friction. And if we're minimizing friction, we're also reducing heat, right? So it helps to relieve heat and minimize friction. So it is a key anatomical modification, adaptation that helps us function, optimally here, right? So this is the key idea. These is kind of difficult to explain in a word. In a lab, you would have a heart, we would dissect the heart, and you would actually be able to see these different parietal layers there. But basically, it is a bag kind of folded on itself, right? And I don't have a good analogy to show you, but so let's say we're looking at here, right? So we're in the inside of the heart, in the actual chamber. We have what we call this endocardium, and this is muscle, the myocardium, and the top of the heart, that fibrous layer on the top of the heart, is part of this epicardium, right? The epicardium, the pericardium, epicardial area. So here we have that layer that extends, and then we have our parietal layer of the serous pericardium, and then the fibrous pericardium. So it's the same, in essence, the same tissue. It's holding the heart in place, but it is then kind of folded on itself. That makes sense. This is filled with fluid. So as the heart moves up and down, that fluid just kind of allows as a lubrication, as a cushioning type of situation. So the pericardium. In addition, we have, again, the different layers of the heart. So from the outside in, right, the epicardium is in essence the visceral layer of the serous pericardium, which I'm never going to ask that on a test. Right? It's just, again, I'm going to focus more on physiology rather than on anatomy. So epi, right? Think of the epidermis. Epi is always on the surface, right? So the epicardium, the quote unquote, the skin of the heart, right? That tough fibrous layer around the heart. Inside we have the myocardium, right? The myocardium is that thick, meaty tissue, the muscle tissue. And myocardium is quite unique in the way that it's deposited, right? So I'm going to come back to this slide in a bit. Let me show you how this looks like. So early in embryonic development, our heart is basically two parallel little pumps. And it stays like that, day 22. At about day 24, we have what we call torsion of the heart, right? That heart kind of does like a twist, and it's kind of, imagine like a figure eight. If I have those, what do you call them? You park your car, you don't want the sun to come in the windshield. I have those those sun visors, those round ones. If you ever have to fold them, you know that you kind of like compress and twist them until they kind of fold on themselves. That's kind of the situation that happens here. And we have then this torsion of the heart. So what ends up happening, instead of having muscles running parallel to the heart, we have this sort of circular, sort of torsioned kind of muscularity there. Right? The best analogy I can give you here, when these things compress, right? Imagine with one finger, you're trying to push toothpaste out of a tube, right? I push the tube, I can push out. If this is the toothpaste tube, pushing out. That will work, but it's not effective, right? If I get my hand and squeeze around the toothpaste tube, then it's going to push toothpaste out easier. But if I squeeze in the middle, some can go back, some can go out. So to prevent that, our heart starts to squeeze from down below, and it continues to squeezing up superiorly, thereby forcing blood out these major vessels there, right? So it's first we have our atrial contractions, and then we're going to have our ventricular contractions from inferior up to superior. So it's a unique system. So the myocardium, again, is the spiral bundles of cardiac muscle cells. So these are those spiral kind of bundles of cardiac cell. Fibrous skeleton of the heart is this crisscrossing, interlacing layer of connective tissue. So the connective tissue is not contractile, right? It's just kind of supporting the muscles, anchors the cardiac muscle fibers. This fibrous skeleton, internal inside the heart, will support the great vessels and valves. It's going to be very, very vital. And this fibrous skeleton will limit the spread of action potentials to specific paths. So all of these are going to be addressed as we continue here. And then the endocardium. Endocardium is like the smooth lining within the lumen, within the chamber itself. So blood is going to be kind of flowing through here. So the smoother we can have that layer, the less friction we're going to have. That's that endocardium. So again, endocardium, myocardium, and then the epicardium there, kind of continuous with the pericardial sac. All right, so chambers, right? Chambers, there's another way of saying chamber is a hollow area, right? So I'm sitting in this room. I'm sitting in my chamber, right? It's this hollow area. There are going to be 4 separate chambers in the heart, 2 superior atria, or one atrium, plural atria. And these atria are going to be separated internally by the interatrial septum. I hope you remember what a septum was. A septum is a little, like a barrier, right? So we know that our left nostril is separate from our right nostril because of that sort of nasal septum. So the septum is a barrier. So the 2 atria are separated internally by the interatrial septum. The coronary sulcus, remember sulcus is like a valley. A sulcus is an indentation, a little groove, right? So the coronary sulcus, also known as the atrioventricular groove, encircles the junction of the atria and the ventricles. Lots of words there, right? So the coronary sulcus, atrioventricular groove, encircles the junction of the atria and the ventricles. I'll show you a picture of that. Now the ventricles are going to be separated by the interventricular septum. And the anterior and posterior interventricular sulci mark the position of the septum externally. Right, lots of words, right? Lots of words here. So let's look at the anatomical sort of frontal view. The patient is laying on their back, and we're looking at it from the front view. So let's find our landmarks. We always look for the apex. So that tells us, okay, we're looking at the front of the heart. Apex is pointing to the left. So we follow the top part of the heart. We have the left atrium. And the little auricle is just like a little ear flap. So auricles increase atrial volume. If you've seen those little hats, one of my favorite characters growing up was Chavo del Ocho, that little the child of the 8th. I don't know how it translates in English. But his little hat, or these little like cold weather hats, they have like 2 little ear flaps that come down. Those would be kind of like auricles. So auricles. So we have the left atrium, the auricle of the left atrium. Over here we have the right atrium, the auricle of the right atrium. Circling the heart all the way around like a crown, right? We say we have that. I'm going back here now. Going back to the coronary sulcus, right? Corona, we talk about the coronavirus. Corona is a crown, right? It's round, it encircles, and it would be set on the top. So it's this sort of round type of shape. So we have a round groove that goes all the way around the heart, that coronary sulcus. I like this term better, right? The atrioventricular groove. It lets us know what that groove is separating. It's separating the atria from the ventricles. Right? And it goes all the way around. It circles the junction of the atria and the ventricles. So above this coronary sulcus, we have the atria. So superior to that, we have the atria. Inferior to that, we have the ventricles. That coronary sulcus or atrioventricular groove there, all the way around. And then back we have the anterior and posterior interventricular sulci mark the position of the septum externally. So this is the ventricles. So we look at our picture here. So this groove, we have a big groove here. The anterior interventricular artery in the anterior interventricular sulcus. It's a little groove that externally distinguishes our left ventricle from our right ventricle. And these grooves are going to serve a purpose. Where you have these sulci, these grooves, that's going to be a little path in which major veins and arteries will be sitting in there. So we have the atrioventricular groove. We're going to have then that coronary artery that runs in that path. We have the interventricular septum, and then we have this big anterior interventricular artery and veins that kind of run in that path. So important landmarks on the external surface of the heart. So just kind of looking a little bit into getting a little bit ahead of where we're going, basically what we're at right now, where we're going to, looking at some of the major vessels. Right? So vessels entering the right atrium are going to be the superior vena cava, the inferior vena cava, and the coronary sinus. Vessels entering the left atrium, the right and left pulmonary veins. And I'm going to really hit this hard, but not just yet. We're going to kind of still look at the sort of gross anatomy of the heart here. We'll look at vessels a little bit later. So ventricles basically are stronger. Well, I should say the ventricles are bigger, lined by more cardiac fibers, because they're going to be the discharging chambers. They're going to be, walls are ridged by trabeculae carneae. I'll kind of show you what that looks like. They have little papillary muscles that are going to be important connecting the valves. And we have some major vessels leaving the right ventricle, which is the pulmonary trunk. The major vessel leaving the left ventricle, which is the aorta. So again, some anatomy here. So we've cut the heart in half. We've removed the anterior half. We know that the patient is still in anatomical position because the apex is still pointing to the left, right? So that landmark that we saw externally, so this is that landmark that we see on the external sort of aspect, that interventricular sulcus, interventricular groove, we see here as that that septum, right? That big septum then that's separating the left ventricle from the right ventricle. Pectinate muscles they talk about here, or I should say papillary muscles. Where is it? Papillary muscles in the ventricles. Papillary muscles. Papillary muscles are gonna basically connect the internal valves, right? So we have this valve, which we call the tricuspid valve, or sometimes it's called the right atrioventricular valve. And over here we have the bicuspid valve, also known as the mitral valve, also known as the left atrioventricular valve. So multiple names for the same parts. Makes it a little bit confusing sometimes. Trabeculae carneae, I don't know how to describe this very well. I don't know if you're fans of scary movies. If you know Freddy Krueger, how his face is all burned and he's got these like ridges and grooves, and that's what the inside of the heart reminds me of, like Freddy Krueger texture, right? And instead of saying Freddy Krueger texture, they call it trabeculae carneae, right? It's this these little grooves and sort of indentations. That's all part of the endocardium of the heart, right? So they're going to get into some valve discussion here. I want to point them out right now, but we have one of the semilunar valves, pulmonary semilunar valve, aortic semilunar valve right behind our atrioventricular valves. So lots of stuff going on in the heart. The big hollow area of the right atrium, big hollow area of the left atrium. I'll address this soon. The pulmonary circuit. Well, I guess I'm gonna just address it now. I wanted to hold it off, but I'll get it done here. So when we look at the heart, if you remember in embryonic circulation, there was two parallel little pumps. They underwent torsion, but in essence, the heart still maintains that functionality. It's two side-by-side pumps, right? Two pumps pushing blood to two different locations, right? We know it's a circuit. It goes all throughout the body, but the right side of the heart is a two-sided pump. So the heart is a two-sided pump. The right side is the pump for the pulmonary circuit. So that makes sense. So the heart is a side-by-side pumps. The right side is a pump that is going to push blood to the pulmonary circuit, basically to the lungs. If you speak Spanish, what is the Spanish word for lung? Right? In Spanish is pulmón, right? Pulmón. So we're pumping blood from the heart to the lungs, right? That's the right side pulmonary circuit. Vessels that carry blood to and from the lungs. The left side has a bit more work to do, right? It's going to pump blood from the heart to the system, to the body system, to the systemic circuit. So the left side is the vessels that carry blood to and from all body tissues. So it does a lot more work. So this picture will kind of show us sort of the circuit. So if we look at colors are significant here. Blood rich in oxygen is shown as red. Blood poor in oxygen is shown in blue. So on the starting on the right side of the heart, right, deoxygenated blood that is given blood to all of the basically the systemic circuit. This blood is poor in oxygen, right? So this blood has to travel to the heart to get pumped to the lungs. So that's the key point of the right side of the heart. Take blood from the body, push it back to the lungs to get oxygenated. So this pulmonary circuit loads the blood with oxygen and it goes back now to the heart, to the left side. The left side now has to pump this oxygen-rich blood to the rest of the body to oxygenate the body, right? So in essence, the role of the left side is to fuel the body with oxygen. So the major organs, your pinky toe, your ear, your eyelid, every little cell in the body has to be basically oxygenated, has to be, oxygen has to be brought, carbon dioxide waste has to be removed, metabolic waste has to be removed, and that's the role of the systemic side, right? Sending blood to the body, back to the heart. The right side, pumping blood to the lungs, and then back to the heart. So the pulmonary circuit and the systemic circuit. Now, if we can envision a work differential, right? So if we notice the heart very, in the center, sort of 2/3 of our chest, it's got to send blood to the lungs. Well, where are the lungs? They're just right beside them, right? The heart is literally sort of bumping into the lungs. So that's a very, very short path. It's a very short journey. The left side is going to have to send blood from the heart all the way to your brain, all the way to your pinky on your left hand, on your right hand, your pinky toes on your feet. So it's going to be a lot more distance that has to be sent. So it's a very big workload differential on both sides. And that's going to have some key consequences here. So we'll get into the path in a bit here. Just want to show you here. So the pathway of blood through the heart. So the pulmonary circuit and the systemic circuit, the right side and the left side of the heart, move equal volumes of blood. So that's important. So remember, we have about roughly 5 liters of blood in the body. Well, each of these circuits moves the equal amounts of blood to both circuits. So we're pushing equal amounts of blood to the lungs as we are pushing equal amounts of blood to the rest of the body. So the pulmonary circuit, the right side of the heart, is a short, low pressure circulation. It doesn't have to pump very, very far, right? It just pumps very minimally. Blood goes from the heart to the lungs and then comes back in. So it's an easy workload that it deals with there. Low pressure circulation. Systemic circuit blood encounters much resistance in the long pathway. So the left side has got to pump blood a lot farther. And there's going to be some consequences that we see there. The anatomy of the ventricles reflects these differences. So if we notice here, right? So there's our chamber, our right chamber, pulmonary circuit, left chamber, left ventricle, the systemic circuit. You can see how thick, look at how fat that is, how thick that myocardium is. Over here, look at how thin that wall is. So form fits function. Again, we have this side of the heart that's having to pump, to really push blood far and pump hard. So over time, that muscle gets a lot bigger, right? Over here, we have a very, very small, very easy job. So that muscle doesn't hypertrophy as much, right? So very, very big differences between the workload of these vessels. Remember, they're pumping the same volume of blood. This is pumping the same volume of blood. This is pumping the same volume of blood. This is just having to pump that volume a lot farther. And this is just very close. Now, take a wild guess. If there is a major problem in the heart, which side is probably going to be the one affected? You know, which side of the heart typically gives us more health problems, the right or the left? Again, normally it is the left. If you said left, yes, that's correct. It's just doing a lot more work. Any machine, if we compare two machines, this machine's doing a lot of work. This machine's doing very minimal work. The machine that does a lot more work typically has more problems, right? Needs more maintenance, that kind of stuff. Well, we don't have the ability to just go do maintenance in the heart, right? We just hope that it takes care of itself, right? But it's typically then the left side of the heart that will be in charge of doing more work and can be more, problem filled type of heart there, or side. A little side note here. I always like to think of this as that person doing barbecue. I don't know if you like to barbecue, but let's say we're grilling out there, we're barbecuing. Normally the chef doesn't come and sit and eat with everybody else, right? Because the chef gets the best, he's cutting, that piece looks good. I'm gonna, take that taste for me. They're kind of snacking, they're kind of tasting as they're, cooking, right? They cook, they sit inside, but they're getting their own, the best parts, the choice parts of meat per se, right? The heart is going to be kind of similar. The heart has to send blood to the rest of the body, but the heart also has to sustain its own myocardium. And the heart gets that first choice, that first highly oxygenated, highly rich source of blood in the systemic circuit, right? So we call that the coronary circulation. So the functional blood supply to the heart muscle itself. We'll get into some of these other things as well here, but again, this is going to be more critical when we cover vessels. I'm going to introduce it now, but we'll come back to it with the actual blood vessel discussion, and you'll have a homework assignment with this and a lab aspect with this as well. So we have arteries that are going to carry blood away from the heart, away, arteries away, and veins which will bring blood back to the heart, right? So in Spanish you say ven, right? Ven, come over here, right? So arteries away, veins to bring blood back, right? So again, our major landmarks: atrioventricular groove, interventricular septum. Remember all these vocabularies, these terms. So we're looking again at the heart. Well, the heart gets its first branch off of the aorta, right? So this pulmonary trunk is actually superior. The aorta is inferior, right? It's deeper. So this one would be more superficial. So that's the more correct term. So pulmonary trunk more superficial, the aorta deeper into the heart. So as blood is leaving systemic circulation, it leaves out this left coronary artery. And if you remember corona, like not just like the virus, right? Corona, because it looks like round. It's a little round virus, round crown. So the coronary artery is going to encircle the whole heart there, right? So our coronary artery goes around the heart. As it kind of goes back, we have that circumflex artery that goes to the back. And then we have this important vessel that goes all the way down the interventricular septum. And we call this the anterior, in the front of the heart, anterior interventricular artery. And it continues back to the back part of the heart, the posterior interventricular artery. We have some of these other marginal arteries, but again, that just kind of gives you a little idea of how this thing kind of goes through the heart, right? So the left coronary artery feeding the left side of the heart, the right coronary artery feeding the right side of the heart. So the names are quite intuitive there. The artery or the veins, kind of a little bit similar, right? So we have the blood that was taken to the left side gets drained back from the left side through the in the back, the posterior middle cardiac vein, from the front, the great cardiac vein. Right? You can see it kind of encircle. From the right side, we have the anterior cardiac veins and the small cardiac veins that are going to bring blood around. Now on the posterior side, we have what we call the coronary sinus. It's a big swollen area, it's a big sort of aggregation of vessels. This coronary sinus feeds blood back into the heart at the right atrium. It's a good homework question right there, right? And I'm going to back up several slides. Where is it here? Let's see, there's a slide that says somewhere. Maybe not. But there's the three. Where's the right atrium? Right here, sorry. So the atria, the receiving chambers. So the atria is going to receive blood from the vena cavas, which we haven't discussed yet, but it's going to receive its coronary circulation back from the coronary sinus. So the coronary sinus feeds into the right atrium, and it kind of helps continue this circuit there. All right, so if we look at the heart in this aspect, what side of the heart are we looking at? If it didn't tell us down here, I hope you can see, well, now we're looking at the back side of the heart. Right? We're looking at the posterior view. How do we know? Because the apex is pointing now to the opposite side, right? So a lot of vessels hanging out back here. We look for our major landmarks, our atrioventricular groove, or the coronary sulcus. Within that coronary sulcus, we have our major vessels sitting in there. And then in the back, the posterior side, we have that big swollen aggregation that we call the coronary sinus. We can see here the inferior below and superior above vena cava. These are the largest vessels, the largest veins in our system, right? Bringing blood back from the legs, lower body, bringing blood back from the arms and the head, right? All going to that right atrium. So right atrium receiving blood from three vessels: coronary sinus, inferior vena cava, and superior vena cava. Here we see then the pulmonary veins. They're going to bring blood back from the lungs. Our pulmonary artery that's going to send blood to the lungs, and then the aorta that's going to send blood to the rest of the body. Okay, we're going to discuss that in the next video. So I hope this is making sense so far. Just kind of trying to give you some terms, some landmarks on the heart itself. Trying to look now at some things that can go wrong. So we always want it to work correctly, but for you medical types, if things work correctly, you're never going to see these people. They're not going to be patients. They're going to be out living a healthy life. So normally what we see with the heart is this idea of angina pectoris, like chest area. So angina is a thoracic pain caused by a fleeting deficiency in blood delivery to the myocardium. So in essence, the heart is being deprived of oxygen. And we say that's a big, it's a bad thing, right? The heart cannot sustain an oxygen debt. So if we're not getting enough oxygen to the heart, those cells begin to become very weak, and those cells can start to die, basically. So angina pectoris is a serious effect, a serious side effect, a serious precursor to what can be now an actual heart attack. Right? And heart attack is a vague term. I want you to start using the term infarction, right? Myocardial infarction. So myocardial infarction is when there is a blockage somewhere along this path, somewhere along the path to send blood to the heart. There is a little blockage of some sort. So it causes then not enough oxygen to get to these cardiac cells. Those cardiac cells start to die. And once they die, they no longer can generate contraction. They're going to be repaired by non-contractile scar tissue. So that's not good, right? So that's a heart attack. So an infarction basically is a vessel problem. It's a vessel problem. It's think of if Interstate 10 was shut down right now. Well, the big trucks carrying your Amazon items are not going to be able to get to the town, right? They're not going to be able to get to El Paso. So the stores, the warehouses are fine, but the transportation issue is causing the problem. So an infarction is a transportation issue. We're not bringing in oxygen the way we're supposed to. It could be a clogged artery, it could be a damaged artery, a little, whatever sort of blockage is in there, depending on where the blockage occurs. Right? If we have a blockage, let's say right about here, if that little area becomes blocked, on the right side, it's going to damage a few cells there. But that person's probably going to be okay. If there's a blockage on the left side, way up here, everything below that clog is going to be damaged, right? So again, some people survive infarction, some people don't. It depends on where that blockage occurs, what type of cells, how many cells, right or left side of the heart are being damaged, right, as to the severity, the complications of that infarction. Now, let's say a person is an infarction, right? Would this call for, hey, let's bring these paddles, right? These defibrillating paddles, clear, should they jolt this person if they are in an infarction? Would that help? I hope you said no, that would just hurt, right? The heart is doing what it's supposed to. The heart is not the problem here. An infarction, the problem is at the vessel level, right? The blockage level. That would have to go in there. We'd have to do some angioplasty, clear out the clogged vessel, do a bypass of some sort. So a very, very different type of problem there. We are going to get to fibrillation problems later, but this would not require the defibrillating paddles here. A little bit of some more anatomy. I'm almost done with the anatomy, and then we'll kind of move on to some other stuff. But let's look here at valves, right? Heart valves. So heart valves are going to basically keep traffic going in one direction. We don't want backflow. We want everything to go in the same direction, have some nice flow. We don't want any turbulent flow, that kind of stuff. So heart valves serve that role, right? They ensure unidirectional blood flow through the heart. And we have two separate categories of valves. We have the atrioventricular valves. And I'll let you kind of visualize, where would an atrioventricular valve be? It's going to separate the superior atria from the inferior ventricles, right? They're going to prevent backflow into the atria when the ventricles contract. And again, more names, right? More anatomy. The anatomists love to name stuff, right? So on the, let's say the right side, to start the right side first, we have three parts. There's three flaps. We're going to call that the tricuspid valve on the right. On the left, we have two flaps. So sometimes it's called the bicuspid or the mitral valve. Mitral refers to the old European, like the caps these religious bishops would wear. They're like a two flap little hat. That's a mitral hat, right? A mitral valve. I jump between the different terms. I like always atrioventricular valves, but again, I will use mitral, I will use tricuspid, I will use bicuspid sometimes. So just whatever pops in my brain at that moment is what I'll speak here. But we know that these valves, the AV valves, are going to be anchored by the chordae tendineae. So the chordae will anchor in these valves to the papillary muscles. And then we have semilunar valves that are going to separate the heart from the major vessels, right? Semilunar half moon valves. They're going to prevent backflow into the ventricles when ventricles relax. We have two, the aortic semilunar valve and the pulmonary semilunar valve, right? So aorta, aortic semilunar valve, pulmonary artery, pulmonary semilunar valve. So that's where these names are derived from here. And again, I will address these in some more detail when we look at all the actual circulation patterns. So we kind of cut the heart in half. So we see then our three cusps, 1, 2, 3, our tricuspid valve, 2, our bicuspid valve, also known as the mitral, also known as the left AV valve. And then here we have what we call the semilunar valves, the aortic semilunar valve and the pulmonary semilunar valves. And to me, yeah, it doesn't look like half moons, but I didn't come up with the names, no. But that's, again, the position of the valves there. Kind of showing you the position here. And in real life, quite a bit different, right? They don't look as pretty as the way that they're drawn by the artists here. Again, there's our, basically our mitral, bicuspid, there's our tricuspid, aortic semilunar, and then pulmonary semilunar. All right, so these little papillary muscles, right? The papillary muscles are critical. We have these chordae tendineae that are actually holding the valve, right? So if I can back up here, back. So there's the valve. These white flaps are the valve. These little strings are the chordae tendineae that are attached to these papillary muscles. So imagine like a parachute, right? We have a parachute. Well, the parachute is being held open by the wind, but we got to have somewhere to hold on, right? And those are going to be these little strings, these chordae tendineae. And in order to stop them from being ripped, we have to have that muscle down below that holds on. So I'll give you some better aspects there. I'll provide better detail. So for now, I'll let you soak all this in. We're almost about, it's about done for the valves. You can see how they work. The next video that I get to may take me a little while today, this evening, or tomorrow morning. I will address these specifically here, right? These different types of valves and the whole circuit of blood flow. So for now, I have to hop over to another Zoom meeting. So again, you'll have a good rest of your day. Start looking at this. It's a lot of stuff. And tomorrow at 3 p.m. will be a live lecture, my first attempt at a live lecture with you all. So see y'all next time here.